Macet, yes, traffic jam everywhere. Yes. But lucky for all of you that today's weather is really good. Not that hot as last week, maybe. Yes, but it's lovely, and it's really good to have you guys here again to share with all of us, especially today especially about nutrition, because yes, this is really important for our patient to what's that to talking about this, yes, and to practice it in our words. So
Jadi hari ini kita itu akan membicarakan atau berdiskusi tentang nutrisi pada pediatric onkologi.
Ya, khususnya pada penggunaan MGT ya.
Ya.
Jadi mungkin teteh-teteh dan dokter-dokter di belakang juga mungkin, apalagi pasien-pasien kita banyak yang sulit untuk diedukasi agar mau menggunakan MGT. Dan seperti yang kita tahu dan yang sudah di-sharing juga tadi oleh tim dari Princess Maxima, bahwa di Belanda ini edukasi penggunaan MGT ini dilakukan pada saat mereka sudah masuk ya, pas awal masuk, sehingga tidak begitu sulit dalam melakukan edukasi. Dan pada saat dikaji pasien harus melakukan MGT, pasiennya gampang gitu, jadi langsung mengiyahkan gitu ya untuk menerima dan dilakukan pemasangan MGT.
So almost all patient in Holland itu menggunakan MGT.
Yeah.
Kalau di kita kan untuk edukasinya aja susah ya. Kalau di sana itu mereka bermain dengan MGT aja sudah biasa.
Betul sekali.
Kayak gitu. Nah, tanpa berlama-lama ya, kita langsung saja panggilkan pemateri kita yang pertama, yaitu
Dr. Vira. Betul, Dr. Vira? Okay, for Dr. Vira, the stage is yours. Kenapa? Iya, betul, belum. Oke.
Berikan tepuk tangan yang semangat dong untuk Dr. Vira.
Good afternoon. Assalamualaikum warahmatullahi wabarakatuh. Ya. Oh, okay. Dr. Sari, is our discussion in Indonesia or in English? In Indonesia because, okay. So our discussion is in Indonesia, so you can translate to Netherlands, right? Yeah. Because our audience is all nurses and my president, ya. Oke, selamat siang. Assalamualaikum warahmatullahi wabarakatuh. Jadi pada hari ini kita akan sedikit menceritakan mengenai masalah pemasangan MGT pada pasien-pasien hemato-onkologi. Mungkin dimulai dengan pemasangan video terlebih dahulu mengenai pemasangan MGT pada pasien hemato-onkologi. Okay, so this is our first video about tube insertion in hemato-oncologist patient.
Assalamualaikum Ibu. Perkenalkan, saya Suster Kori. Saya yang kebetulan di sore hari ini. Ya, tadi ada advice dokter bahwa anak ibu harus dipasang MGT.
Apa itu ya Sus ya MGT?
Nah, MGT itu selang untuk makan yang dimasukkan lewat hidung sampai ke lambung.
Apakah dari rekan-rekan sekalian ada yang pernah mengalami kesulitan dalam pemasangan MGT kepada pasien?
Kan anak ibu sekarang refleks hisapnya lemah, jadi nutrisinya takut tidak tercukupi untuk adik.
Kalau lewat mulut itu nggak bisa Sus, harus dipasang selang MGT itu?
Ya, karena kondisi anak ibu sekarang sedang lemah, ininya kan refleks hisapnya belum bisa. Jadi takutnya nanti tersedak.
Karena MGT di kita masih merupakan hal yang tabu bagi beberapa pasien, karena beberapa pasien beranggapan bahwa pemasangan MGT itu butuh perawatan yang intens. Belum juga penolakan dari pasien yang sering melepas MGT secara spontan.
Jadi mendingan kita pasang MGT dulu sampai adiknya benar-benar bisa menyusu langsung lewat mulut.
Tapi itu gimana Sus? Nggak apa-apa, nggak bahaya buat anak saya? Nah, rekan-rekan semua, untuk lebih meyakinkan keluarga atau orang tua pasien dalam hal pemasangan NGT bahwa NGT itu sangat penting dilakukan atau diberikan sebagai pemenuhan nutrisi secara parenteral. Itu perlu edukasi yang lebih intens.
Nah justru nanti kalau misalkan tidak dipasang NGT, takutnya anak ibu mau tersedak. Ya kalau NGT kan langsung sampai ke lambung, insya Allah aman. Jadi gimana ibu? Apakah ibu bersedia?
Ya kalau itu baik untuk anak saya, ya saya bersedia sus, nggak apa-apa.
Oke kalau begitu saya siapkan dulu alat-alatnya. Nanti ibu mungkin tanda tangan di surat persetujuannya.
Ya boleh.
Oh ya, Bu, bisa bantu saya nanti kepalanya diangkat sedikit ya. Sedikit. Plester ya supaya keluar bisa. Jadi batasnya sampai plester ini ya Bu ya. Kita coba tes dulu ya. Siap. Ada ya Bu ya? Plesternya biar kuat ya. Nah ini tanggal pemasangan hari ini. Jadi nanti kita bisa ngitung dari tanggal 10, tanggal berapa kita harus ganti lagi? 17 ya, 17 ke 18 ya. Demikianlah sekilas video tentang contoh pemasangan NGT pada pasien. Semoga video ini bisa bermanfaat untuk rekan-rekan semua. Terima kasih.
Okay, that's our video about tube insertion in one of our hemato-oncologic patient. Dalam bahasa Indonesia ya berarti ya. Oke, jadi sebenarnya di sini bagi para rekan-rekan perawat semuanya dan juga teman-teman residen. Jadi mengapa sih pemasangan NGT itu sangat penting terutama pada pasien-pasien hemato-onkologi patient? Apakah kita harus menunggu pasiennya mengalami malnutrisi terlebih dahulu atau pada saat kita mendapatkan pasien sudah tegak diagnosisnya atau pada saat penegakan diagnosis sudah sejak awal kita melakukan proaktif NGT? Mungkin ada yang bisa sharing atau berdiskusi kenapa sih sebegitu pentingnya pemasangan NGT pada pasien-pasien hemato-onkologi, terutama pasien-pasien yang sedang menjalani kemoterapi. Oke. Ada yang bisa sharing mungkin dari teman-teman perawat atau dari teman-teman PPDS? Apakah kita harus menunggu nih anaknya, anaknya masih mau makan, penegakan diagnosis, kemudian ternyata udah dibiarin aja anaknya masih makan. Ternyata pada saat berjalannya waktu mungkin minggu ketiga, minggu keempat pada saat datang dia kemo anaknya udah jelek. Anaknya udah turun tuh, udah undernutrition misalnya. Kira-kira kenapa ya? Kita perlu proaktif atau kita tunggu aja anak yang nggak bisa makan? Gimana? Proaktif, kenapa kita harus proaktif? Mengapa? Mengapa kita harus proaktif? Terutama coba duta-duta hemato-onkologi di sini.
Ya, mungkin ada dua dokter. Yang pertama, nutrisi merupakan salah satu indikator keberhasilan dalam kemoterapi. Jadi kalau misalnya tidak dibarengi oleh nutrisi, maka kemoterapi juga sia-sia ya dok ya.
Ya.
Nah yang kedua side effect dari kemoterapi sendiri adalah mukositis. Jadi mukositis pada orang-orang dengan kemoterapi itu biasanya tidak hanya di mulut sariawannya tuh banyak, tapi semua jalur pencernaan sampai ke
mukosa.
Betul. Nah makanya mengapa kita harus perhatikan nutrisinya gitu. Jadi untuk next step kemoterapi dia bisa terus melanjutkannya sampai tuntas. Kayak gitu dok.
Ya, itu kan sebenarnya pro-nya ya. Sebenarnya ada nggak sih cons-nya gitu? Sebenarnya ada nggak sih? Sebenarnya tuh itu pro-nya banget, bener. Cuma ternyata di sisi lain kita tuh sulit loh memberikan atau melakukan proaktif NGT. Apa tuh kesulitannya yang bisa teman-teman hadapi di ruangan? Yang tersulit ialah penolakan dari keluarga. Oke, parental misperception itu paling sering. Jadi mereka menolak karena merasa anaknya akan sakit pada saat dilakukan pemasangan NGT. Itu yang pertama. Yang kedua, merasa malu anaknya kalau pulang dengan menggunakan NGT. Dan itu hampir terjadi, hampir seluruh pasien-pasien kita merasa begitu ya. Begitu pulang, di sini pasang. Begitu pulang, lepas. Di rumah jelek. Di sini pasang, di rumah begitu mau pulang, lepas. Jadi memang itu juga sangat. Dan karena melihat orang tua seperti itu, anaknya secara emosional juga jadinya menolak. Jadi memang emosional dari pasiennya juga, terutama pasien-pasien yang pre-adolescence ya, adolescence itu rata-rata pasti sudah langsung menolak. Jadi itu memang merupakan salah satu hal tersering yang kami temui dan agak cukup sering di ruangan. I don't know in Prince Maxima about patient in hemato-oncologist patient, adolescent patient, do they just say yes, or you have to have approaching like a special approach to get proactive NGT? Because in here there's a lot of parental misperception or like emotion. They need emotional support to give proactive NGT. How about in Prince Maxima?
I think having a feeding tube for the first time, that's always like a step for
Like
parents.
a big challenge, right?
Yes, of course. I'm not sure if you need to translate it. I think it's okay. Yeah, it's okay. The eerste stap. Yeah, it's always, the first step is always a big step for parents. It's never easy because it's new. They don't know it yet.
Langkah pertama pasti sulit untuk orang tua karena mereka tidak ketahui apa itu NGT itu.
Most of the times, the education about the feeding tube starts when the patient is newly diagnosed.
Yeah.
So when we have the patients in the hospital and they have the first conversation with the doctor about the treatment, we also tell them that probably there will be a lot of medication that the patient has to use, and that's why we most of the times use a feeding tube, and in some cases we don't need it, but most of the time we need it. So when they're just in the hospital, we start talking about it.
Jadi kalau di Belanda pertama kali udah didiagnosa sudah langsung dibahas kemungkinan ada keperluan untuk pasang feeding tube karena masalah pengobatan dan nutrisi. Jadi orang tua udah tahu dari awal apa itu dan bisa persiapan juga. Terus dijelaskan juga tidak setiap anak akan perlu.
And it feels early to talk about it, sometimes even before the treatment is started. But at the same time, then it's part of the whole process.
Yes, correct.
And it's something, we explain to the parents why do your child needs the therapy, because we want to make the child better. But at the same time, it's important in that moment to give an explanation about the feeding tube as well, because then it's part of the treatment. So the decision in a later moment, it's not made by the parents, but it's made by us as the care team, or it's made by the doctor. So they don't have to make that decision themselves.
We have to make that decision.
We're making the decision for them.
The team.
And we need to explain why it's so important. It's not like a choice. It is something that they really need because they need the energy and they need the fuel to get better.
It's quite interesting. It's not a choice. It's not a choice. Jadi sepertinya memang kita harus memberitahu kepada keluarga pasien bahwa itu bukan pilihan, mau atau tidak ibu. Bukan, it's not a choice. Ya.
Ja, maar zo'n gesprek wordt een beetje heen en weer lopen dan, denk ik. Maar
Oh ya, karena gambarnya nggak kelihatan ya, Mas Ivan.
dat wil je,
Yang
maar
sebelah
waarom
sini
wil je
nggak
dat
kelihatan
doen?
di TV. Bisa nggak sih kelihatannya agak sebelah sini? Ya, nggak bisa ya. Nah,
Kijk, dat zijn we.
ya, oke, that's nice, thank you. So saat ini yang kita lakukan, kita memberikan pilihan. Jadi kita menerangkan bahwa akan dilakukan pemasangan NGT. Apakah ibu bersedia? Apakah bapak dan ibu bersedia anaknya dilakukan pemasangan NGT? Tapi it's quite interesting. It's not a choice. The decision made by us, the team, not by them, right? Gitu. Because it's for their child's health. So maybe it's we have to underline this. It's not a choice, but it have to. Yeah, is it right? Okay.
Het is een onderdeel van de behandeling. Dus naast de chemo is dit ook een onderdeel.
Dan kalau di Belanda, tadi Merwe juga bilang, ceritakan dari awal mungkin merasa terlalu cepat, tapi kalau sudah dari awal diceritakan supaya orang mengerti itu sisi satu dari semua perawatan dan pengobatan.
Like it's a whole treatment, yeah, from the start. Yeah.
Can I say something?
Yeah, of course.
Because the parents don't know what kind of choice they have to make. So we need to give them the right information and the honest information, and then lead them through the decisions. And also in Holland, we have a lot of folders or pictures of the center, and all of these kids have a bald head and a feeding tube. So it's it speaks to the vision, and parents can get used to that picture of the children.
Ya, jadi di Belanda orang tua kita mesti dampingin untuk pilihannya karena mereka kurang informasi dari awal, jadi kita yang kasih. Dan kalau di Belanda juga banyak folder pasien. Terus di folder pasiennya foto dan visualnya juga anak-anak semua pakai feeding tube, sama mungkin rambutnya tidak ada supaya orang kalau melihat sudah terbiasa. Oh, itu sisi satu dari cara prosesnya.
Okay. For parents, I think parents have an image in their head of what it's going to be like because they don't know.
Yeah.
Just like children. So when they see an example of how it's going, for example, the video that you, I think in the head of the parents, it is different. They're the children who are having a terrible time and they're getting it out of their nose for 10 times, and it's gonna be worse for a couple of weeks, and that is not the case. This morning I was at the ward.
Yes.
I'm not sure if you heard it. And there were parents who didn't want to have their child. They didn't want him to have a feeding tube.
Yeah.
And then I showed a video of us, how we did it in Holland. And I mentioned to the parents, like, look, the child was crying while we inserted it.
Yes.
But just
After that?
Yeah, but after that, between 10 seconds, the kid was sitting up. And I asked the parents, does this kid look like he's in pain now? And they said no, because she was laughing again. She was making a decision of what kind of sticker he wants on his tube. So the parents saw the example of a child that wasn't happy when he was getting the feeding tube in, but afterwards he recovered so quickly, and it changed the image of the parents in their heads. And then they said, okay, we're gonna do it. And we just received a picture that the child now, like 2 hours later, is having the feeding tube. So it's the example for parents that makes the image in their head more safe.
Okay.
Ya,
Number
jadi,
2, it's important to make an image. Okay, you.
Ya, jadi orang tua kadang pandangannya beda. Jadi mungkin di dalam kepala mereka, oh, feeding tube itu sesuatu buruk, nanti anaknya nangis-nangis, akan tarik-tarik, akan sakit. Tapi kalau kita kasih contoh seperti video ini, itu bisa edukasi mereka. Dan Merwe kasih contoh, tadi pagi ada anak yang orang tuanya asalnya menolak karena takut. Terus Merwe kasih video dari Belanda. Memang waktu masukkan anaknya nangis, tapi 10 detik setelahnya sudah duduk, malahan nanya-nanya, oh, stiker apa saya boleh di pipi saya. Jadi Merwe kasih tahu orang tua, ini kan Berarti sebagai contoh, anaknya malahan tidak sakit, semangat, terus abisnya orang tua memang kasih izin untuk kasih, dan tadi sudah dapat foto, sudah berhasil. Yang asalnya nolak, udah dipasang.
Yeah, nice. So number one, it's not their decision, it's our decision. And number two, how we change their perspective. Yeah, we have to give example like that. Yeah, so we can change the parents' perspective, right? Okay. And actually, what kind of tube do they have in Maxima? It's like a silicone tube, or
Yeah, we have
you
two kinds
change-
of tubes.
yeah.
But maybe maybe we can let it go around, right? Is that an idea?
Yeah. Oh yeah, sharing Maxima. Okay.
Because we have different sizes.
Yeah.
Ukurannya
We can put
ada
them out
tiga
of the-
macam, ukurannya beda-beda.
So you can.
Jadi
Take
mereka akan sirkulasi tube yang diguna di Belanda. Bisa silahkan.
Is it a silicone tube or like a? Is it a silicone? You change it once a week or once a month or?
Not made with rubber latex.
Every 6 weeks. That's our challenge, because in here we have like a plastic tube. We have to change it once a week. That's why the parents, yeah.
Ya, masalahnya di sini tube
Maybe.
setiap minggu dirubah, tapi di Belanda bisa di tempat selama 6 minggu.
Yeah.
Get them here.
Yeah. Yeah, rubber latex, yeah.
No.
Yeah. Not made with rubber latex.
Ja, ik weet niet wat zijn nog introducties.
Ja.
Ik vind het ook een mooie markt gevolgd en wat zij doet.
Oh yeah, I heard in Maxima there's a video about inserting tube, right? Yeah, maybe you can play it.
Ja, dat is meer een soort, het is een soort van, ja, een ander type plastic, maar ik weet niet precies wat voor type.
Oh, no. Yeah. Yes.
Yeah.
Younger children, we use more
Like animal, something like that. Okay.
Also something that is like better taste.
Okay.
Because they're more moving.
Yeah.
Teenagers.
This is for teenagers, right?
Yeah, I think teenagers a little bit more because
Yeah.
they're not that
Yeah.
capable, you know what I mean?
Yeah.
I think to fix it, shade it, something else is needed in here because of the sweat.
Oh, yeah, because
So now we saw it's at the nose, and maybe I don't know what's the right thing. In Holland we put a sticker on the cheek, but the children are more sweaty in here than in Holland.
Sometimes you put the rest of the ear, and you put the stickers.
Yeah. I think in Holland.
Mereka sedang
There's like a sticker. Then the picture is going on that sticker. Then there's this white sticker going on there. Yeah. And then to make it. Yeah. I left the whole roll and because I think so. Yes. Oh, sorry. I thought it was. Yeah. Sometimes with the babies, the small babies, we have and then it will only
Continuous.
like this. Yeah, a grip without like this. Only this. But
Yeah.
not a big one.
Yeah.
So
Bigger
I
respect.
think the stomach will make their own
Yeah.
speed, and all the children we have to pump.
Okay.
And then it's possible to give portions or just 24 hours.
24 hour, yeah, like
Backpack?
Oh yeah, backpack, yeah. I saw in Australia. Australia too. Yeah, it's cheap.
Ja. Je moet even eerst van de voorbereiding, Judith, dat de verpleegkundige het laat zien.
Okay. Here is the video about inserting tube insertion in breast maxima.
Yeah, what is important to know, we have children in Holland who do it themselves or like this kid are not crying at all. But I especially used a video of a child who didn't like it, who was crying, because that's like, I think 90% of the time, the children between 1 and 8 years old who are having it for the first or the second time, they don't like it, they're crying, and that's okay. It doesn't mean that the inserting didn't go well when they cried, because I think that is a normal reaction to an abnormal situation.
Ya, jadi Merwe akan kasih lihat video contoh pemasangan di Belanda, tapi dia sengaja pilih video dengan anak yang menangis di waktu pasang. Soalnya di sana juga ada anak yang nggak nangis atau mereka bisa aja kalem, tapi 90% anak kecil pasti akan nangis dan karena itu sesuatu yang mereka tidak mau.
And what's important when we are inserting, before we inserting it, I always explain to the parents what they can expect when we are going to insert the tube.
Dan penting juga sebelum pas pemasangan, mereka selalu menjelaskan ke orang tua apakah mereka yang bisa melihat di waktu memang sejak memasang. Dan tadi saya lupa terjemahkan, tapi penting juga untuk mengingat kalau anaknya menangis, itu bukan maksudnya pemasangannya bersalah atau apa, itu memang reaksi normal kepada sesuatu yang abnormal sebetulnya untuk anak.
And yeah, and what I'm always on forehand, we need to discuss with the parents. There's a big possibility that the child is not going to undergo it without a little resistance. And before you're inserting it, you need to know for sure that parents are okay with us holding their child a little bit, because the head needs to be still. But you need to bespreken. You need to discuss that with parents on forehand, because when you're inserting it, you want to make sure that everyone is on the same level, is on the same page.
Dan penting juga untuk berbicarakan dengan orang tua sebelumnya, ada kepastian kemungkinan besar anak akan berontak. Berarti perawat akan mesti pegang anak-anak supaya diam di waktu memasang. Tapi bahas sebelumnya supaya orang tua juga setuju dan tahu itu yang kita bersama semua harus lakukan untuk menghadapi bersama anaknya diam.
Alright, well, the first video, what we're showing is that the nurse, she's educating the child just a couple of seconds before it's going to happen. So she's showing it.
Jadi perawat
on
ini
the doll.
sedang kasih lihat anak di boneka apa yang akan dilakukan sebentar lagi. Jadi contohnya di boneka memasangan sondes.
In Holland, we use water to insert the tube, or we're trying to use water because when children are swallowing, it's easier to insert the tube. And swallowing when you have no spit is very difficult.
Jadi di Belanda di waktu pasang diguna air supaya anaknya lebih gampang untuk menelan di waktu pasang tubnya.
Not every child is being able to drink water. Some children are crying and they don't want to drink water. And what we're doing with the small children is blowing in their face, but like, so.
Kadang-kadang ada anak yang tidak bisa telan airnya karena menangis atau tidak mau, tapi ya jadi perawatnya tiup ke mukanya.
Yeah, you wanna try to have the shock effect, so children are swallowing.
Jadi supaya mereka kaget terus menelan.
Oh yeah, and some small children, it's a bit weird, but it's helping. And with the babies, the pacifier, maybe they know it in English.
Jadi kalau bayi kecil kadang ada dot kan, jadi karena itu yang menolong dikasih dot supaya menelan, ya refleks.
Alright, well, We're going to show you a video of that same child who is getting a tube in, who did not like it. She was a little bit mad at me, but we did it.
Anaknya marah di waktu dipasang, tapi akhirnya berhasil.
Yeah. All right, so you see the child is knowing what's going to happen, but she's still, on forehand, she's playing with me and the doll. And during that time, the nurse can prepare.
Oh, ya. Jadi sebelumnya diajak main distraksi dengan boneka, anaknya udah tahu apa yang akan terjadi, terus perawatnya siapkan barang di waktu main.
But when it's going to happen, she does not like it, and we need to help her a little bit.
Jadi di waktu benar-benar mulai pasang, ya anaknya tidak suka kan, berarti kita mesti menolong untuk benar lanjutkan prosesnya.
And this is just some water.
Itu
Yeah,
air putih.
and mommy is not liking it either, but she's helping, and we always call it helping. We never say we're gonna hold you or we always say we're gonna help you. The words are important.
Jadi kelihatan ibunya juga tidak suka karena anaknya tidak suka, tapi kalau kita membahas kita selalu bilang kita menolong. Jangan bilang kita pegang, kita tekan, kita apa, tapi kita menolong, kamu diam.
And what's important is that when it's done, immediately tell the child, okay, you're done. Because then she knows that she can close the procedure. And she wants to choose a sticker, so you see how quickly she recovers afterwards.
Dan setelah sudah berhasil, pentingnya juga untuk langsung bilang ke anaknya, udah selesai, supaya mereka juga tahu selesai dan bisa relax. Dan kelihatan barusan dia udah boleh pilih stiker dan sudah cepat.
In Holland, we have the rule that we need to test it on a strip. So before we could do it your way, but now we need to see what is in their stomach. So we need to take some stomach fluid and put it on the sticker. Stomach fluids. We don't need the stomach fluid. And then we need to check it. And then you know that it's okay.
Kalau di Belanda, untuk tes apakah benar masuk cukup jauh, ambil cairan lambung sedikit, terus dites strip, dites apa benar cairan lambung atau bukan.
And sometimes it's difficult because when children are sober for a very long time, they don't have anything in their stomach, so you don't get something out. And then we try to tell them, you drink something or you eat something, and then and go for a walk, and then we try it again like an hour later. But only if we're almost sure that it's at the right place. When children are coughing a lot then we need to check it some more. Yeah.
Ya, kadang-kadang tidak ada cairan karena anaknya kurang makan, terus dia tidak ada di waktu itu, ya bisakah nggak apa-apa anaknya jalan-jalan dulu, minum sesuatu dulu, nanti sejam kemudian coba lagi untuk tes stripnya. Tapi itu hanya kalau hampir yakin itu sudah masuk. Sebetulnya kalau ada kepikiran tidak masuk, ya mesti cari tahu dengan cara lain.
And when we're not sure if the feeding tube is on the right place and we can't get any stomach fluid, then we have to make an X-ray.
Jadi kalau tidak yakin dan juga tidak bisa mendapat cairan untuk tes strip, ya protokolnya di sana untuk membuat X-ray.
Yeah, okay. And when we can, we try to combine this procedure when the patient is sleeping for, like, for example, BMP function or lumbar function. Then we do it when the patient is sleeping. Yeah. But it is important that it's not the only way to do it when they are sleeping. So they have to learn how to do it when they are awake, how to get to know the procedure.
Kalau kebetulan ada prosedur lain yang dengan sedasi, di sana seringnya sekalian dilakukan feeding tube di waktu prosedur lain seperti lumbar function atau bone marrow function. Tapi itu penting juga untuk jangan hanya memasang di waktu sedasi. Jadi anak juga mesti pengalaman memasang di waktu bangun.
But sometimes when maybe like the tube is in for already 6 weeks, but 2 days after there is a procedure with sedation, then we wait for 2 extra days to combine it.
Jadi kadang-kadang kalau di sana misalnya waktu masa expire-nya tube-nya 2 hari sebelum prosedur lain, di sana ya ditunda dulu aja supaya sekaligus.
Yeah. And what's important, what we always discuss with parents, but also with the children, are two things. The first thing is name that the children just can keep on eating and drinking. Because some children and parents think that when there is a feeding tube, that they cannot eat. So that can be a reason why parents don't want to have the feeding tube. So it's important to notice that. And the second thing is to explain to the parents and the child that it's temporary. It is not. It doesn't have to be as long as the whole treatment is. We have children who are being treated for 2 years, but the feeding tube can be, for example, for 2 or 3 months. I never say the time because it can be longer. But tell them it's temporary and it's possible that in some time the child doesn't need it anymore.
Ya, jadi penting sekali untuk bahas dengan orang tua juga 2 hal. Pertama, di waktu dipasang feeding tube, anak masih bisa makan seperti biasa lewat mulut. Soalnya itu salah satu alasan orang tua mungkin menolak karena mereka takut anak nggak bisa makan seperti biasa lagi. Nah, kedua, untuk jelaskan juga ini walaupun kalau dipasang itu hanya bisa untuk sementara. Misalnya jangka pengobatan dan perawatan 2 tahun itu waktu lama, tapi tidak tentu pemasang feeding tube-nya diperlu selama 2 tahun itu. Siapa tahu hanya beberapa bulan aja. Tapi ya coba, Merwe selalu coba untuk jangan kasih waktu karena kita kan tidak tahu butuhnya akan berapa lama.
And I think an important thing for you is, I always, because in Holland, parents are sometimes having difficulties with accepting their child needs a feeding tube as well. But what I always do, or what we do as a care team, is trying to figure out what's the reason they don't want it. Because sometimes it's because of the culture, for example, or the things they expect from it. It can be because they're scared to hurt their child, but it can also be because they don't understand the information that has been given. So we need to know why they're saying no. Because sometimes, as like this morning, it was very easy to convince the parents of this option. But sometimes, even in Holland, it's more difficult because when a teenager who is 17 says, no, I don't want this, we need to know, okay, but what's the problem? Why don't you want this?
Ya, jadi di Belanda juga sama, ada sering juga orang tua atau anak yang menolak. Dan untuk care team itu pentingnya untuk cari tahu apa alasannya untuk menolak. Jadi ada orang tua yang mungkin tidak paham informasinya dan itu perlu lebih edukasi. Ada orang tua yang merasa anaknya akan kesakitan. Oh, dan mungkin juga masalah kultur. Jadi untuk mereka kulturnya ya tidak biasa sesuatu seperti feeding tube. Jadi karena itu menolak. Atau seperti apa contoh atau yang susahnya kalau teenager, anak remaja 17 tahun, kalau mereka menolak saya tidak mau, ya itu susah juga. Kita harus cari tahu kenapa, apa alasannya.
I just wondering, is it enough if we want to check the NGT tube insertion? Is it in the right place or not by using the stethoscope and then we check for the gas? Because in here we usually just doing it, not like check the fluid digest, like something like that. Is it not enough?
It's what we supposed to do, or what I was used to with my hospital before I went to the Business Maxima Center, like even 10 years ago. This was our way too.
So it's so very, very last year, right?
Well, yeah, I'm not sure when it changed, but there became a point where they said it's not enough, and then they made this decision that we always need to check it before we can use the feeding tube for medicine or food.
Oh, ya, jadi dulu sama protokol untuk cek, sama seperti di sini dengan cek dengan stetoskop dan apa ada gasnya, tapi di Belanda di dalam waktu ya ada perubahan protokol, jadi sekarang ceknya dengan strip, tapi dulu sama cara ngeceknya sama.
It's because we in research we found out that if you have the tube and it's in the lungs, you still hear the plopping of air, so it's not good to not safe.
Jadi alasannya memang karena salah masuk terus masuk ke tenggorokan ke paru-paru, tetap aja bisa suara yang mirip, Pak. Saya makanya cek ini ya kurang optimal. Protokolnya dirubah.
I see. Ya, boleh, silakan.
Baik, terima kasih atas kesempatannya. Menarik pembahasan ini. Sebetulnya untuk kami di lapangan, selama ini bukan hal yang tidak menjadi masalah yang cukup berat untuk kami membujuk pasien-pasien kami untuk pemasangan NGT. Sebetulnya itu bukan hal yang berat untuk kami gitu. Jadi selama ini walaupun ada penolakan pada fase awal, mereka pada akhirnya mau karena mungkin kami sebagai perawat bisa membantu mereka untuk mengatasi masalah misalnya kekurangan informasi, maka kami akan jelaskan sesuai dengan yang mereka perlukan gitu. Jadi sebetulnya pemasangan NGT ini bukan masalah yang sulit untuk kami, jadi tidak menjadi kendala yang berat penolakannya. Hanya yang jadi masalah, bahkan teman saya itu sudah melakukan penelitian di HCU Asnawati tentang pengukuran pemasangan NGT yang aman. Karena dari beberapa jurnal pun sudah dijelaskan bahwa untuk mengukur hal yang tepat untuk memeriksa posisi NGT yang tepat itu yaitu dengan hal yang sudah dilakukan seperti di Nederland tadi. Cuman yang jadi kendala adalah di kita belum ada fasilitas untuk melakukannya gitu. Jadi teman-teman di lapangan itu sudah melakukan penelitian, menganalisis jurnal. Ada beberapa jurnal yang sudah kami analisis. Bahkan kami menemukan beberapa rumus untuk mengukur bagaimana cara pemasangan NGT yang tepat. Hanya untuk di dewasa. Kalau untuk di anak kami belum menemukan. Dan barangkali untuk ke depan kami bisa dibantu bagaimana caranya
pengajuan berarti ya.
Nah, seperti itu difasilitasi karena kami pun sebetulnya tertarik dan kami sudah memahami bahwa ini bukan hal yang tepat begitu. Terima kasih.
Terima kasih. Pertanyaannya.
Ja, kan je eigenlijk de faciliteiten, ja, maar dat is ook een lastige vraag. Ja, om dan de faciliteiten te geven om dan op het niveau functioneren zoals het eigenlijk hoort.
Yeah. Maybe you can check if you can order the tubes like this.
That it's the right thing to do, but our facilitator didn't. Yeah, the availability of the
Because once in a week is different than once in 6 weeks.
Of
Once
course.
in a week is a lot. Yeah, exactly. Yeah. Yes.
Ya, jadi masalahnya juga salah satu pun kalau seminggu beda sama 6 minggu. Jadi tapi ya untuk fasilitas ya itu masalah lebih ke ekonomi.
And how about the insurance for the feeding itself?
The insurance covered only the NGT, plastic once a week NGT.
Okay, and the
Only
feeding?
covered that.
So for the nutrition?
For the nutrition covered if the patient's inpatient in here, but if the patient at home, they have to buy their self. Yeah.
So that can also be a reason. Yeah. Because that can also be a reason why parents don't want it, right? If they have to pay by it. If they have to pay for themselves.
So actually, if medical tools paid by the national insurance, so all the provider have to register to the national formularium. So I don't know whether the silicone ones already.
Silicon's already.
That's so it's no problems at all. It's just our user.
But the problem is continuitas. Maybe about 3 weeks, and then the silicones NGT is sold out everywhere.
So
and
but
then
the purchasing, no,
2 months later, there will be the.
To interrupt, I think in Yogyakarta they are teaching the parents to make their own nutrition for the tube feeding. So maybe we can exchange the information and teach the parents here as well.
Jadi barusan ada pertanyaan juga tentang tentang kalau orang di rumah nutrisinya tidak termasuk asuransi, berarti orang mesti bayar sendiri. Tapi di Jogja ada orang tua yang belajar untuk membuat nutrisinya sendiri, jadi supaya bikin nutrisi makanan sendiri. Jadi mungkin bisa ya set up sesuatu untuk bagi informasi untuk gimana cara mendukung orang tua untuk tetap teruskan nutrisi di rumah.
So maybe a lot of experience, but they are too ashamed to talk in the big forum. That's why we grouping the audience into small groups, and we have like this one flip chart, so they can like share their stories and share the challenges, and then we will rotate. Yeah, rotate, and maybe we made some notation and will be present at the end. So, Bapak Ibu, Teteh, ini kan tempat duduknya udah berkelompok ya, nanti kita akan diskusi mengenai hal yang sama. Barangkali tadi belum ada hal-hal yang sebenarnya lebih sering terjadi gitu, tidak semudah itu gitu kan ya. Nah, jadi nanti kita akan diskusi di kelompok kecil. Di sesi terakhir atau nanti di sesi akhir boleh? Oke, because we have only
hello guys, hello again. As Pediatric nurse, I want to ask you about the basic thing that we have with our patients is we got a lot of hemato-oncology patients, which means there are a lot of patients with low thrombocyte levels. Sometimes it's kind of complicated for us and becomes struggle for us when the thrombocyte levels is super low. We were afraid if we inserting the feeding tube or the nasogastrid tube, it will be there will be bleeding on the track. So I'd like to ask about the management that you have maybe in Netherlands, and in your standard maybe how low the thrombocyte could be when we want to insert the tube. Thank you so much.
Thank you for your question. We don't have a lower bottom line. We don't check it before. We can just replace it or bring a new one in without checking the thrombocytes. Also in the home care, because our patients going home with tube feeding, and the home care is also providing tube feeding in the change of the tube. But the difference is in the Netherlands and here is that in the Netherlands, when there is a bleeding, we have a directly access to thrombocytes. And I think it's different here. But next to that, we never saw a bleeding after bringing in a gastrogenic tube.
Ya, kalau di Belanda tidak dicek trombositnya sebelum pemasangan, jadi seperti pemasangannya bisa di rumah sakit, karena di rumah juga, berarti kalau di rumah juga tidak dicek. Tapi ada bedanya di Belanda, kan akses kepada trombosit atau untuk transfusi di sana lebih gampang daripada di sini. Tapi dia juga mau katakan di waktu pemasakan pengalaman mereka belum pernah melihat pendarahan setelah memasukkan NGT tube.
And before we had a minimum thrombocytes, but after research we made a decision that it's not necessary anymore.
Yeah. Waktu zaman dulu memang ada minimum trombosit, tapi setelah peer review research bikin keputusan untuk tidak diperlukan lagi di dalam protokol.
Ya, jadi selama ini mungkin misunderstanding dari NPM ketika mau memasang NGT, selalu misalnya PPDS dok nggak bisa dipasang nih dok karena trombositnya di bawah 20.000. Kami berpikir itu memang dari tim hemato-onkologi. Tapi ternyata dari hematonya sendiri kita nggak pernah bilang nggak boleh. Jadi nggak usah takut. 10.000 mereka 1.000 pun memasang gitu ya. Jadi nggak usah takut mau berapapun trombositnya. Kalau memang perlu pemasangan NGT, pasang aja proaktif NGT. Jadi nggak usah menunggu ada trombositnya harus 50.000 misalnya atau harus di atas 20.000, nggak perlu. Karena lebih penting pemasangan itu dan nggak akan jadi bleeding perdarahan yang banyak itu nggak akan. Gitu ya Mel ya.
So maybe it's good to mention that in general, we don't put in a new feeding tube when a child has severe mucositis already. because then it is a really painful procedure. And more complications with the bleeding. Yeah, but maybe in such a case, we still have the thrombocytes. Then we think about giving a thrombocyte transfusion as a prophylaxis. You're sure? Because we are checking it. We are used to that. So we are having a discussion now about whether or not
sedang berdiskusi apakah
really
ada
good to discuss
kasus yang diperlukan trombostektosis.
interdisciplinary, whether or not there's a higher risk if you have a child with a mucositis and you give the nasogastric tube. The experience is that you don't see any bleeding even though the child has the mucositis, right?
Yeah, but
Yeah, so then the thrombocytes are also low. Low thrombocytes, below 10, and the mucositis.
But as you can see, it's good that the nurse and the doctors are communicating about this as well. It's very important.
yeah, and I think
Thank you.
I think the most important thing is that we want to be before the situation of extreme mucositis and the patient has no feeding tube already.
Ya, jadi pentingnya memang untuk sudah pemasangan NGT tube sebelumnya sudah jadi mucositis atau trombosit rendah sekali. Ya, supaya diskusi ini tidak terlalu susah juga ya.
And I think that when there is a case like you mentioned now, we start with enteral feeding. We skip the sonde, we don't do the tube, and then we do IV feeding.
Terus mungkin di situasi yang dikatakan sebagai dari Dr. Judith, yang kalau mucositis berat sama trombositnya rendah sekali, mungkin mereka akan skip NGT, tapi langsung ke enteral feeding, parenteral feeding.
Okay.
I'm curious to other experiences here with.
Okay, any other experiences here from our pediatric nurses? Our lovely pediatric nurses here.
Pengalaman yang lain, apa ada yang lain lagi?
One chocolate for one question. So, tadi udah ada dua, Mel. Tadi udah ada dua loh, Mel. Oh, oke, boleh. Langsung dikasih.
Saya mah bukan matre. Ini mah serius bertanya. Dokter Punten ingin bertanya terkait tentang kapan kita memutuskan untuk memasang NGT. Karena kan tadi dokternya menyarankan untuk as soon as possible gitu kan. Tapi standar khusus saat kita memutuskan this is the time gitu.
Judith. Dr. Judith,
We do it as directly as possible. So we place the tube. Sometimes even when the patient, for example, with a neuroblastoma patient, we know that it will be a difficult treatment, that there from the beginning will be very much medicine, and the patients are really young, like somewhere around 1 and 3 years old. So then when we start the treatment and there is already a lot of weight loss and trouble with feeding in the history of the diagnosis, then we start directly with a tube before we start with the chemotherapy or at the same time.
Before. Jadi, as soon as possible. As soon as the diagnosis is already
And if they don't want to do it, but then try to do it before the mucosite starts, because then it's getting more painful for the children.
Jadi penjawabannya memang secepat bisa, itu memang secepat bisanya. Jadi udah dari awal, misalnya di kasus neuroblastoma yang sudah tahu perawatan dan pengobatan akan berat sekali, lebih-lebih dengan anak yang kecil, dipasang aja langsung, kadang-kadang juga kalau bisa sebelum kemoterapinya memulai.
And we know that parents can have difficulties to discuss with the patient to take the medicine, or they will tell the patient every day, the whole day, oh, please eat, have some drinks, and it becomes a really struggle. and then we will discuss it with the parents that it can be a relief to put a feeding tube in, and they won't have that arguments during the day.
Dan juga untuk kasih tahu orang tua, kadang-kadang anak yang kurang makan kan orang tuanya karena sayang bisa makan dong, minum dong seharian, itu bisa menjadi beban juga untuk anak. Berarti kalau pasang NGT tube itu membuat anak lebih rileks dan terlalu stres mengenai makanan.
Yeah, for older children, but also for the younger children, it's also important to tell them that it's not something we do to punish them for not eating. It is something we do because their body just cannot process the food. So we need to explain that it's not punishment. It is something we do to help.
Dan juga mesti dijelaskan ke anak-anak ini bukan sesuatu yang dilakukan sebagai hukum karena mereka tidak makan, karena tidak mau makan, tapi ini sesuatu untuk menolong, untuk menjadi sehat. Jadi supaya anak-anak enggak merasa dihukum dengan feeding tube.
Yeah, maybe it's important to mention that there's a different situation in the Maxima as compared to here. So we use the feeding tube for medicines, as Kim explained, or when a child cannot eat well anymore themselves, then we use it for additional feeding. Here, many of the children enter the hospital already very undernutritioned. And we know that 20% of the children who are undernutritioned have 20% less survival. So here, you often already have to start directly with improving the nutrition and at the same time find a diagnosis and start the treatment. So it's parallel.
Ya, jadi masalahnya di sini juga beda daripada di Belanda. Kalau di sini keadaan nutrisi anak yang masuk seseringnya sudah buruk, dan kalau nutrisinya sudah buruk, ya ada 20% survival rate-nya berkurang. Berarti lebih penting sekali untuk di sini untuk pasang dari awal, soalnya ya mesti dikejar untuk menambah nutrisi anak yang sudah malnourished.
And I think we all already do that. But what helps me is sometimes explaining to the parents that we do understand that it is a lot. It is a lot for parents to adjust because you're figuring out that your child is sick and he needs to start treatment and you've got to do the feeding tube. So I think we all do that already, but sometimes I'll check to myself, okay, if I would be in this position, it would be a lot. So it is normal that parents in the beginning sometimes just feel a little bit, they hold it off, and we need to give them sometimes some time. It can be a day or 2 days, because then you're still in the beginning, but you give them 1 or 2 days and then repeat some information because it's so much for parents to adjust to everything.
Jadi penting juga untuk kita mengerti dan mengingat untuk orang tua yang ada anaknya sakit, hal-hal yang mendatang yang mereka mesti hadapi itu banyak. Berarti ada feeding tube, ada mesti cari diagnosa, mesti ini, mesti itu. Jadi kadang-kadang orang merasa bebannya banyak, berarti bisa awalnya menolak dulu. Tapi kadang-kadang butuh waktu sedikit aja, mungkin sehari 2 hari untuk memproseskan, untuk setelahnya bisa meneruskan apa yang perlu dilakukan.
Okay. Thank you. Is there any question? Yes, please.
Wait, should I bring it? No. Come in. It's okay. It's good for my. It's gym.
Terima kasih untuk kesempatannya bertanya dari saya perwakilan dari Komite PPI Pencegahan Penularan Infeksi Rumah Sakit Hasan Sadikin. Yang saya tanyakan terkait tadi di video itu ada saat pemasangan pada anak. Tetapi karena saya lihat di situ apakah memang standarnya tidak ada pemakaian APD sarung tangan. Satu itu, yang kedua. Karena secara tindakan itu berisiko adanya kontak dengan sekret. Apakah aman walaupun itu ke anak gitu. Karena standar kami di Sp.A di rumah sakit setiap ada tindakan yang dengan berisiko ada cairan tubuh pasien, sekret, itu wajib memakai APD, gitu, sarung tangan.
Yeah, in the protocol, the gloves aren't prescribed only if the patient is in isolation. Because when you're insert the feeding tube, you want to feel what's going on, and also you have to put the stickers on. So when it's possible, we prefer without the gloves.
Kalau di Belanda memang protokolnya untuk tidak pakai sarung tangan, kecuali kalau anak atau pasiennya di ruang isolasi. Ada beberapa alasan karena untuk merasakan memasukkannya butuh feeling yang lebih bagus dan kadang-kadang sarung tangan bisa jadi halangan, dan keduanya dan kadang juga untuk pasang stikernya dengan sarung tangan bisa ya lebih susah. Jadi di sana protokolnya memang berbeda.
Jadi hanya menggunakan alkohol ya, you only have
cuci tangan.
5 moments.
Ya, hanya cuci tangan dengan alkohol.
And it's also not a sterile procedure, because when the tube is getting out maybe 1 day later, we put it in water and clean it, and then we use the same tube again.
Jadi ini sebelumnya juga bukan prosedur steril, makanya tidak pakai sarung tangan. Jadi kadang-kadang juga kalau tubnya mesti sementara dilepaskan, dicuci dulu di air, nanti dipasang lagi.
Oke. Jadi prinsipnya pemakaian sarung tangan ini di kasus tertentu gitu ya? Tadi
Ya,
kan
betul. Ya, hanya kalau pasien terisolasi dan ya.
Only in isolated patients.
Low immunity patient.
Maaf, ada satu lagi pertanyaan, boleh? Ya.
Satu loh.
Boleh? Maaf. Ini kasus pemasangan NGT yang untuk perawatan di rumah, yang harus berlanjut di rumah. Nah, bagaimana untuk pencegahan jangan sampai terjadi infeksi untuk pemasangan NGT yang anak yang dipasang di rumah? Karena yang namanya anak itu ya istilahnya dunia bermain masih keluar, kontak sama lingkungan sekitar gitu. Nah, itu bagaimana cara pencegahan jangan sampai terjadinya infeksi pada kasus pasien yang dipasang di NGT di rumah untuk anak. Ya, terima kasih.
Yeah, at home it's the same as in the hospital, but in the Netherlands we live more in house, so children will play outside, but they live inside of the houses. I think it's maybe a bit cleaner than outside in the village in here, and we will wash the tube before replacing it, and also when the tube is going out and it has been inside for like 4 weeks, then we will put a new one in.
Kalau di Belanda, ya situasi lingkungannya beda. Kalau di Belanda, orang hidupnya banyak di dalam rumah. Ya anak memang main di luar, tapi seseringnya di dalam. Jadi juga debu dan lain-lain kan di sini pasti di kampung sama di Belanda situasinya beda. Tapi tetap kalau di Belanda, berarti kalau di rumah tubnya dilepas sebelum waktunya, cuci masukkan lagi. Tapi kalau misalnya sudah di waktu akhirnya ya tetap diganti sama tub yang baru. Jadi misalnya kalau masih ada 2 minggu, harusnya 2 minggu lagi diganti, tapi ya ganti yang baru saja. Berarti ya hanya seperti itu aja. Tapi selain itu prosedurnya sama seperti di dalam rumah sakit.
Ya. Are there any other questions? Maybe from our residents, maybe? Yes. You will be given NGT session.
And then when we like day after that, when we have like visit again, the patient already eat, and then so what is your tips to avoid those situations?
Well, sometimes it helps, and the patient will, is going to eat, but sometimes they just can't. And then what Merwe said, it's not a punishment, but we have to tell them we want to help them, and we'll stop with the complaining about they're not eating, and just go on and on and on about feeding. So it's just to help. I think that's the most important to tell the children.
Yeah, and also have some positive, because when children are getting their nutritions and with the feeding tube, they also have the possibilities with their parents to enjoy some positive times. But when there's no feeding tube and there's no fuel inside, children are tired and they're feeling like very low energy. And also everyone the whole day staat in het teken van, how do you say that in English? The whole day is about eating and taking medicine, because they need to be on that all the time. So there's no positive thing anymore. It's like being sick, but also having people talking to you about medicine and food all the time. So there's no. So also for parents, it's good to know that when the feeding tube is in, there are parents who are telling me afterwards, oh, finally I can just enjoy being with my kid again without having to tell them to do something all the time.
Ya, jadi kadang-kadang ada yang ancaman makan terus anaknya makan, oke, tapi di banyak kasusnya ya anak tidak bisa makan, nutrisi memang kurang. Jadi kita coba untuk menggunakan NGT tube sebagai ancaman. Hanya mesti dibilang ke orang tua sama anak ini hanya untuk penolong. Dan kata Merwe juga banyak akibat positif habis NGT tube. Soalnya kalau anak tidak punya energi apapun, nanti seharian hanya menjadi mengenai makan. Jadi seharian hanya fokus ke makan, mesti minum. Jadi anak capek juga. Tapi kalau ada NGT tube, mereka dapat banyak energi. Nah mungkin bisa lakukan hal lain yang fun dengan orang tuanya. Dan sesering juga, Merwe ada orang tua yang bilang, aduh, sekarang punya NGT tube. Finally sekarang saya bisa main lagi sama anak saya sedikit dan tidak harus hanya pusing suruh dia makan. Jadi pentingnya juga untuk jangan coba untuk seharian maksa makan.
Okay.
Ada lagi yang mau coklat?
Oh, yeah, that's good.
And the last thing for me, maybe it's helping, maybe it's not, I don't know. But in Holland, putting in a feeding tube, it's one of those things that I don't like doing. Like I know that it's necessary and I know that it's helping, but the procedure itself, it's something I don't really like, because it's in your face, so you cannot really distract. And the feeling, it's not really painful for children, but it is a hard feeling. I've tried it myself, the feeding tube, because I wanted to know how it felt. Yeah, and Kim did it as well, because that is one of the things we can try, right? But I will never tell.
The nurses have to during school. We all try to put a feeding tube in as well.
Yeah.
Jadi
then it's so good. Yeah.
Karena Merwe mau cerita juga, dia katanya ya mungkin saya nggak tahu menolong apa tidak, tapi kata Merwe ya untuk saya untuk memasang feeding tube itu juga bukan sesuatu yang saya senang lakukan, soalnya itu sesuatu di depan Anda dan anaknya tidak suka, ya itu sesuatu yang ya bukan exercise yang fun banget, tapi itu sesuatu bagus juga untuk realisasinya. Dan katanya dia juga pernah coba untuk masang diri sendiri hanya untuk mencoba gimana perasaannya, tapi terus kata Jaccoline juga, tapi waktu di sekolah perawatan itu memang wajib untuk semua perawat pernah coba memasang feeding tube.
Di sini ada yang udah pasang NGT belum teteh?
No, but it's something I never.
Sendiri ya maksudnya ya.
And I think it's important to always be honest with patients. So if patients ask me, for example, teenagers, is it going to hurt? I always tell them, well, my experience, I didn't think it was hurting me, but I didn't like the feeling. And I'll never tell a child again, it's tickling a little bit. No, it's not tickling a little bit. It's because that's, you want to be honest with your patients. And it's more than just a little tickle in your nose. So let's just, it's
Ya, jadi karena Merwe pernah coba, dan sekali misalnya anak remaja menanya kepada dia, apa sih merasanya akan sakit atau tidak? Jadi dia jawabannya ya sakit tidak, tapi enak juga tidak. Tapi dia juga nggak akan bilang ke anak kecil, oh itu hanya getek dikit. Soalnya ya enggak hanya getek sedikit, lebih. Jadi, tapi pentingnya memang untuk membahas yang wajar, seperti apa pengalamannya kalau dipasang.
Is there any other questions? We still have 3 chocolates, right? Oh, we have a lot of chocolates.
If there's no question, it belongs to me.
Oh. maybe not a question. Is there any experience? Bad or good experience about inserting tubes? Yes.
2 chocolates, Veganes.
Seneng kan? Ya, ada yang minta.
Okay, I would like to share and ask maybe for not only for you guys, but with Dr. Vivi also maybe. We have a lot of experience with patients with internal bleeding and a lot of them having gastric bleeding. So when we put a tube, we didn't know before, but when we put a tube, there are blood coming out from the tube. So we usually decompress it and just like, dialirin gitu. And then after that, we do the gastric lavage per 8 hours or per 6 hours, according to the situation of the patients. But there are some different ideas about when to start the tropical feeding. Because sometimes the liquid is not clear enough, but sometimes it's like a liquid of the gastric liquid, like the yellowish one liquid. But some of the ideas is you can start tropical feeding as long as there are no stosa or there are no bleeding. But at some other ideas, you can start the tropical feeding when the liquid is clear only. Maybe you guys have some experience on the something, then could you share to us about the exact ideal time for us to start the tropical feeding in the patients with internal or gastric bleeding? Thank you so much.
When there is a bleeding, we're mostly very careful, and most of the times we do enteral feeding, so no tube feeding. So it's only a tube for afloop, but there's enteral feeding, so there's no specific time management. I think maybe
if you have a nasogastric tube which is still producing a lot, then you know for sure that there's no passage from the stomach to the bowel, and that is not a good time to start feeding. But as soon as you see diminishing the production of the tube, then you can start with minimal enteral feeding, which is actually protective of the mucosa of the gastrointestinal lining. So for example, 5 mils per hour, just a little bit. And if that goes fine, then you can extend that to really feeding the patient.
Jadi kalau ada gastric bleeding, biasanya ya tidak kasih nutrisi lewat NGD tube-nya, tapi tube-nya hanya untuk lavage saja. Tapi kalau masih ada banyak fluid cairan yang keluar, berarti mungkin ada obstruksi ke lambung, ke usus. Berarti itu bukan waktu bagus untuk memulai makanan. Tapi waktu cairannya mulai berkurang, ya itu bisa coba hati-hati mulainya mungkin 5 ml per jam untuk testing. Tapi ya gitu. Ya, tapi biasanya untuk keputusan untuk memulai itu juga sering kerjasama dan konsultasi dengan dokter bedah juga. Jadi kalau di Belanda mungkin di sini beda ya. Kalau di sana di Belanda kadang-kadang orang dokter bedahan kadang-kadang ikut memikir kapan memulai makanan lewat NGT tube. Soalnya di bidang bedah kan sering juga pengalaman dengan NGT. Tapi saya tidak tahu apa di sini sama apa tidak.
That all depends on what is the cause of gastric gastric fluids that are not passing. So if there is like, I don't know, a mucositis and there's a paralytic ileus, that is a different setting as to whether that was after a surgery and there was a bleed. So then we would ask the pediatric surgeon also. But you can also have patients who have had Finkelstein and then a gastroparese. Those patients need a different approach. So for those patients, you can use the tube until the duodenum to feed the patients, and sometimes they still need the gastric tube hanging out to get rid of the fluids from the gastric. So it all depends on what is the problem in this patient, how you approach.
Ya, jadi memang pengadapannya memang tergantung kasusnya. Jadi bisa konsultasi misalnya dokter bedah kalau misalnya habis tindakan terus masih ada ileus, atau kalau seperti kasus keduanya mungkin masalah gastroparesis, kadang-kadang bisa berpilihan juga untuk tubnya lebih jauh masuk ke duodenum, dan separuh NGT tubnya juga masih digunakan untuk lavage. Jadi ya tergantung sekali kepada situasinya juga. Jadi tidak ada protokol sekarang mesti mulai caranya segini mesti ya. Jadi mesti ik denk dat je zegt dat je als een team echt moet overleggen. Jadi sebetulnya sebagai tim perawatan mesti bikin keputusan bersama kapan waktunya untuk benar-benar mulai.
And previously, Dr. Sari already also had a question about what if the patients take out their nasogastric tube. So we did the insertion following the advices, but then they do like this.
Because in patient in hospitalization, they usually take off the NGT. Maybe every day we put it and then they take off. Tomorrow we put it and then they take off. So is there any maximal how we deal with it? How we deal with it?
Most of the time it depends on the age. So when it's like a small baby and it's taking it off because of an accident, the baby is not remembering it. So then we do it every time. Then there's no limit. Yeah, but when there is like an older child who knows it, well, most of the times when they mostly do it like 2-3 times, and when they see that we are directly putting it back, it takes all maximum of 3-4 times that they try, and then they stop pulling it out. Yeah, it's trial and error.
Ya, jadi pengalamannya di Belanda ya tergantung juga umur anak. Jadi kalau misalnya masih bayi terus menarik NGT tube-nya yang nggak sengaja, ya itu mah tiap hari pasang lagi sampai tidak ada limitnya. Kalau anak yang lebih besar yang udah mengerti, tapi biasanya pengalaman habis 3-4 kali makin masuk mereka sesuainya akan mengerti untuk tidak lepaskan lagi.
Yeah, yes, action reaction. Because the thing is, it sounds harsh, but when they are getting it out and we don't put it back in, then that's the reaction we give, and then they know, okay, now I've, I win. It's like,
Jadi kalau misalnya dia lepaskan, terus mereka tidak langsung masukkan lagi, ya itu mereka pikirnya, oh aksi saya lepaskan, reaksi mereka nggak langsung dipasang, berarti positif untuk mereka. Tapi kalau langsung dipasang lagi, ya untuk mereka tidak ada guna untuk lepaskan, soalnya langsung dipasang lagi.
Yeah, and it's funny because most of the time we see it with children, like you said, 2 or 3 times, and the third time it's like, oh no, and then they're putting back their hands because they just know, oh, if I do this, then it's gonna go back in again. So children are smart and they learn very quickly. But it's sometimes it feels a little bit harsh, but we help them.
And with the little babies, it can be because of them being onrustig, discomfortable, and they are looking for something to grab. And if they can, then we have to make sure to give them like a little cuddle or a toy they can grab, because then they will experience more comfort.
Jadi mengenai anak besar, memang kata Merwe ya lucunya memang abis 3 kali mereka mungkin mau lagi, tapi enggak jadi, soalnya saya ingat langsung dipasang lagi. Jadi anak pinter dan pasti mengingat konsekuensinya. Tapi kalau mengenai bayi, mereka seseringnya lepaskan karena ya lagi tidak nyaman, tangannya gerak-gerak, berarti kita mesti kasih sesuatu lain yang mereka bisa pegang, seperti boneka atau sesuatu lain supaya tidak menarik-narik tubuhnya.
And it's the first 24 hours are crucial, we say, because that's the first 24 hours you can really feel the feeding tube in your throat. So every time they're swallowing, they're feeling the feeding tube. And I think after 2 days, 24 hours, something like that, the tube, your throat is getting used to the tube. And then I really have children who can just eat after a while, but they think the feeding tube is, it's easy, so they don't want to take it out anymore because they're like, yeah, all my medicine can go through it, and because they don't feel it. But the first 24 hours, it's important to distract, so you don't think about the feeding tube all the time, and also drink some lauw, not very hot, not very cold. How do you say that? Lukewarm? Is that a word? Oh, lukewarm. Yeah, so it keeps it supple.
Berarti setelah pemasangan, hari pertama 24 jam itu paling krusial untuk anak tidak lepaskan. Soalnya di pertama 24 jam pertama mereka masih kerasa di tenggorokan. Tapi sehabis sehari mungkin 2 hari, tenggorokannya sudah biasa dan mereka seperti tidak merasa lagi. Dan malahan kalau anak sudah lama mengguna feeding tube, kadang-kadang untuk mereka ya gampang, malahan nggak mau lepaskan lagi, soalnya ya obatnya lewat situ, etc. Tapi pentingnya memang 24 jam pertamanya, dan berarti pentingnya untuk di hari pertama itu untuk kasih anak banyak distraksi, supaya dia nggak terus mikirkan ada tube-nya, dan ada ya hal lain yang bisa distraksi mereka untuk melupakan dan membiasakan diri.
And I think one important detail is when parents do a blended diet. So when they mix the nutrition themselves, still when the patient is having a sonde, it's important that they don't do like really spicy food, because that can be painful for the stomach even when there is mucositis.
Pentingnya juga kalau ya tadi sudah bahas, kadang-kadang orang tua yang membuat nutrisi sendiri yang masuk ke NGT tube-nya, kalau mereka mix sendiri, hati-hati jangan terlalu pedas atau yang dengan banyak herbs. Banyak bumbu-bumbu yang tajam, bumbu-bumbu yang tajam, bumbu-bumbu yang tajam. Tidak pedas, betul. Soalnya itu bisa ya itu buruk untuk mucositisnya sebaiknya.
Okay. I want to make sure about the Yogyakarta they made by their own, because as long as I knew that there's nothing except the milk can be given through
formula,
and formula can be given, so you can like blended food to the NGT.
There was a nutrition was joining our palliative patients discussion, and she told us when it was about the feeding that she has a formula that she can share with the parents. It's a formula. I don't know. It's a formula.
Because in the bigger adolescent or adult, they usually need like solid food and get blended and then put
solid food through the NGT.
Yes, so some parents they want to make the feeding by themselves, so we call it blended diet. But they really have to cook it really long, and then they use the fluid of the cooking and make it very, very thin, like vegetables. But the parents, they do it, but it's a lot of work to do it yourself. Yeah, you have to be careful.
Jadi hanya mesti waspada, ada orang tua yang membuat nutrisi sendiri, tapi prosesnya memang rada sulit dan lama, soalnya cairannya mesti ya benar-benar mencair dan makanannya juga mesti lama dimasak dan supaya tidak terlalu banyak serat-serat juga, soalnya takut obstruksi juga di sondanya. Tapi barusan membahas yang dari Jogja itu dietisnya, dia ada formula sendiri yang dia mungkin bisa share.
We will contact.
Or the nurse educators can ask.
Yes, I will.
So before our session, because we have like several chocolates left, so we will give you questions and please raise your hand. It's like easy question, it's super easy. So where is our guest came from?
Chobi.
Yeah, that already. Yeah. It's just like, you know, step 1, step 2, step 3. Yeah. Which kind? Which center? Yeah. Where? Princess Maxima is where? Where is it? Where is it? No. From you and you. No.
Kotanya di mana?
Utrecht. Ya, Utrecht. Ayo kasihin aja. Kasih aja. Yeah, maybe next question Dr. Vira will have like mass spirit. So what is one indication putting a gastric tube? Why we have to proactive?
Why we have to put a proactive NGT as soon as
Kenapa
possible?
kita harus pakai NGT lebih aktif?
Awal.
Teteh ayo
menunggu
maju.
anaknya malnutrisi.
Ya, ya, jawabannya adalah supaya ya gimana?
Udahlah itu.
Ada berapa lagi coklatnya? Sebutkan jenis makanan yang bisa dimasukkan ke NGT. Ya, angkat tangan.
Setelah di blender.
Apa? Sebutkan apa? Selain makanan apa? Kalau kita masukin ke NGT apa? Yang kalorinya tinggi, warnanya putih. Oke.
Iya, apa makanan cairan namanya Ibu? Bu Mimi? Hah? Ya, enteral feeding namanya apa? Susu. Atau disebut dengan kalau susu formula yang
formula pabrikan, kemudian ada juga
yang kalorinya lebih besar dengan protein energy ratio yang lebih besar kita sebut dengan
high density formula.
Ya, boleh.
Oke, nanti kita masih ada sesi lagi, jadi keep on the chocolate
Blender
for the
juga boleh,
residents.
Dok.
Ya. Jadi silakan Ridwan, kita kayaknya sudah selesai.
Oke.
Baik, dengan berakhirnya diskusi mengenai pemasangan NGT, berarti sesi pemasangan NGT sudah selesai. Berarti saat ini saya akan memberikan kepada MC untuk acara berikutnya. Terima kasih. Assalamualaikum warahmatullahi wabarakatuh.
Baik, terima kasih Dr. Vira yang sudah.
Sekali lagi dong, berikan tepuk tangan yang meriah buat Dr. Vira. Sangat sengit sekali ya diskusinya.
Luar biasa sekali.
Luar biasa sekali.
Mendapatkan insight baru ya, khususnya dalam pemasangan NGT yang mungkin sangat tidak jarang ya, sering sekali kita temukan di ruangan, khususnya di ruang perawatan.
Oke. Simpulannya, NGT placement is very important for
Yes, it is.
patient oncology, especially for pediatric oncology.
Of course.
But with the proper assessment, right? Jadi kalau assessment kita baik, otomatis kita kan bakal menentukan nilai yang baik untuk pasiennya. Benar nggak? Terkadang karena pasiennya banyak, pasien kemoterapi, kita itu jarang memberikan assessment yang baik pada pasien. Jadi nilai minus 2 SD yang seperti itu ya, itu terkadang kita lupa. Padahal itulah yang menentukan indikasi dipasangnya NGT atau tidak.
Yes, because sometimes a lot of patient in our words, nutrition assessment is missed to be assessed. That's why after this meeting, we hope that this indicator, we know that this is important. This is need to be assessed in the first time that the patient come to our word.
So, jangan menunggu sampai pasien itu pertama apa? Malnutrisi, betul. Trombositopeni, fibrinogenitopeni, jadi mukositis. Betul. Jadi yang pertama dia first step-nya adalah assessment kita yang baik. Oke.
Baik, mungkin cukup sekian untuk sesi diskusi nutrisi pada sore hari ini. Kita akan melanjutkan ke acara selanjutnya.
Oke.
Kita tutup dulu mungkin ya untuk acara diskusi kali ini. Wassalamualaikum warahmatullahi wabarakatuh. Good afternoon everyone. Have a good day.
Thank you very much.
Kita mau ngingetin nih untuk hari Selasa dan Rabu kita ada nurse session lagi setiap jam 9 sampai jam 2, di mana di masing-masing harinya kita akan membahas modul yang berbeda. Khususnya untuk perawat nih wajib ikut lagi ya besok jam 9 sampai jam 2. Di mana modul 2 kita akan membahas apa teh?
Membahas tentang bagaimana early diagnosis cancer for pediatric oncology.
Ya, betul. Selama jam tersebut harap dimanfaatkan dengan baik ya untuk mendiskusikan apalagi untuk para perawat pediatric oncology. Dan untuk hari Rabunya kita nanti akan membahas mengenai apa teh?
Modul 3. Sepertinya Kang Bian tahu modul 3 tentang apa?
Apa coba? Apa?
Tentang bagaimana proses eksavasasi.
Nah.
Apa lagi?
Padahal saya yang translate ya. Padahal saya yang translate modelnya ya.
Ya. Jadi nanti di modul 3 kita akan ada 3 topik.
Betul.
Nah, penasaran? Makanya harus hadir ya.
Iya, betul sekali.
Oke. Oh ya, diingatkan kembali kalau sekarang kan kita luring ya, kita hadir di sini. Mungkin kalau untuk 2 hari ke depan nanti kita akan share linknya karena kita akan via Zoom. Jadi jangan lupa berikan pertemuan terbaik ya, karena ini akan sangat menarik ya materi-materinya dan mungkin itu buat bekal juga di ruangan.
Betul sekali. Jadi jangan lewatkan ya teman-teman. So yeah. Dan besok kita akan ketemu lagi. Sampai jumpa di besok hari. Wassalamualaikum warahmatullahi wabarakatuh. Hatur nuhun.
And for the residents still here because we will have another meeting, especially on clinical reasoning. So for the residents still in the room. Thank you. But of course, the case will be from your side, right? Okay. Ke depan kita kayak morning case saja. Ayo ke depan. Mahasiswa yang dokter Yadi juga ke depan aja, nggak apa-apa. Ya, oke. And for you,
Help the interaction. Yes, it will be so nice if they are not shy. Yeah, normal answers, and I will try. I will try my best, but you know. No need problem. Just need to push.
Oh, great! You're already coming in the front. Good.
Yes. Diajakin teman-temannya biar banyak. Duduk depan.
But actually, we were allowed from Dr. Sari to use the chocolates also in your session.
Chocolate's still here.
So we
But
hope.
don't worry, they don't need chocolate. They just need me to point their name and they will ask. Don't worry.
Okay.
Yeah,
Okay.
it will be fine. Duduk di depan. Okay. Can we start it? Because we already 50 minutes. Yeah.
From the back, come sit.
You can,
Di
sit,
belakang,
you can sit in
please.
front, please.
Silakan duduk.
Okay. After that, you can go to bathroom. To the bathroom. Okay. Yes. Let me start for this. Yes, I will be the moderator. Okay. Okay, everyone. Thank you for your time. Now we will go to the next session.
Can we start the presentation?
We will have this. I think it's a very interesting session that we can talk about the clinical reasoning in pediatric oncology diagnosis. So there will be 3 world-class speakers in front of us. Is it Dr. Judith, Dr. Arjenne, and Dr. Nurmelani Sari? She's prepared for the case. So Arjenne will be present the case, and it should be interactive. So if you have something to ask, if you have something in your mind, just ask. You can raise your hand, you can just take the microphone and ask, because the point of this session is how to be interactive. So we can learn about the case, and also from the question we can learn about how to manage this patient that Arjenne will be present. So Arjenne, the time is yours. Please present your case. They can ask every time, isn't it?
Yes, they
All
can
the time.
ask as many questions as possible.
No need
The
to-
more the better, and there are no wrong answers. So it's always good. This is about brainstorming about the patient. So maybe somebody can close the door. That's a little bit more quiet. So you're on call and you receive a phone call from Banyumas, and they see a 4-year-old boy, and he presented with fatigue and bruises. That's all you know. Now we need to think what can be wrong with this boy. So what is your very first quick differential diagnosis without any structure, just brainstorming? What can be the problem with this boy?
We can start from the three. Yes. You can pass the microphone.
The first diagnosis for this patient is like a suspect leukemia or anemia or shock with this patient.
Yeah. Okay, so leukemia, anemia, shock. Very good suggestions, all of them.
Any other? Please, from the left side.
Is there any chronic fever?
No, just the diagnosis first. Then the other information will be given after.
Because
you agree with?
What was your idea? What was your differential diagnosis that you wanted to test with this question?
For the bruise, maybe I give kind of coagulation problem with hemophilia. Maybe.
Think about
Yeah,
the
so
hemophilia.
coagulation problem, that's a good one.
Are you think about different diagnosis with the infection? That's why you asked about the fever. Yeah, different diagnosis. Maybe the infection.
Yeah,
that
infectious causes, yes.
Please pass it to your friend. Yes. One more. Give me your suggestion. What is your differential diagnosis for this? If you have this.
In this patient, I think first hematologic disease or infections, and then some
What? Immunological disorder? Or you think about immunological disorder?
yes.
Like what?
Some myasthenia, I think, but in myasthenia with no brace.
You think about the myasthenia gravis.
This is,
Yes.
Okay, so we in our minds we have made some kind of a list of possible causes of this problem, fatigue and bruising. So now you can ask a few questions to try to make some more structure in your thinking.
Yeah. Okay. Next, now you can ask additional question. What do you think to broad up your differential diagnosis or to eliminate differential diagnosis? What do you think? Fever, and then what?
Yeah,
else that
fever was mentioned already. That's a good one.
What else that you want to? Yeah.
Thank you. I want to ask about when the bruises will appear more, and when the fatigue appear in this boy, and is there any problem that appear in this 4-year-old boy, and since when the problem appear in this boy? Thank you.
Yeah, that's a very good suggestion as well, to ask more about the timing. So, for example, that could help you differentiate between some inborn problem of coagulation or a new problem. So that's a very clever question.
Any other question? From the back, please.
Well, I can show you what I thought about. So this was my first raw differential diagnosis, and most of it you have already mentioned. Leukemia, or another malignancy with, for example, bone marrow metastases, deficiency, like iron deficiency, vitamin B12, folinic acid, aplastic anemia, metabolic disease, autoimmune disease, or a bone marrow failure syndrome, or myelodysplastic syndrome, severe infection, and battering. I hope you will include that in all your differential diagnosis with bruising, because it's very often overlooked. And Judith was, yeah.
Oh yeah, and the addition that was mentioned by the clotting disorders is also a good one, eh?
Yeah.
So, and
Very
then
good one.
subsequently reducing thrombocytes and hemoglobin. Yeah.
Yeah. So if you want to make a little bit more structure in your thinking, there are several ways of structuring a problem. One of the ways to do it, but there are several good ways. I like to structure like there's decreased production of cells, increased consumption of cells, or there's loss of cells. And you can use it also if you make a differential diagnosis, for example, for hypokalemia or well, anything else either. There's a lot of medical problems that you can make a differential diagnosis based on this system. So if you think this is a boy with fatigue and bruising, one of the possible reasons is that there's low platelets or bleeding because of a coagulation problem. Another coagulation problem may be combined with anemia because of the fatigue. We're not sure yet, but that could be possible. So if this is our hypothesis and we think about decreased production of cells, which diagnosis could fit with decreased production of cells from the list that we made just before? So the bone marrow produces the cells.
Can you show the last diagnosis? So which one is for the production is become less from this differential diagnosis? Which one? Please, you can answer.
I think it's bone marrow failure syndrome.
Yeah, that's correct. Yes.
Any other?
I think that it is possible if there is a plastic anemia of this patient.
Yes. And more? So in bone marrow failure and aplastic anemia, in both situations, the bone marrow does nothing. And there are also situations in which the bone marrow would like to produce something, but it's not possible. So what of those diagnoses are fitting with that? So that the bone marrow would like to do it, but it's not possible because of, and then you have to fill it in.
Which one? Which one do you think for that cause of the problem from this diagnosis? Not because of lower of the production, but it cannot produce. Which one?
Maybe we can ask the other way around. How does it work in leukemia? Why do you have an anemia and a thrombocytopenia in leukemia?
Because in leukemia patients, it has a leukocytosis and induce anemia and thrombocytopenia. And
do you know how? How does that work? Because the disease is in the white blood cells in leukemia. But why is there anemia and thrombocytopenia?
Anyone can help? What is the pathogenesis of leukemia? So there's a decreased number. Why? Why? Yeah, go ahead.
I don't know, maybe this is the answer, but I want to give opinion that the cells is failure to produce the mature cells, so the leukocytes is decrease.
Yeah. I think it's a very good try, but it's a little bit different. So I will explain. So, but you did a good try. When you have leukemia, there are a lot of blasts, and blasts are just misfit white blood cells, and they so they don't help you defend against bacteria, viruses, etc. And they divide too quickly, so they become a lot, and then the whole bone marrow is filled with these blasts. Actually, that's the reason why many new leukemia patients complain about pain in the legs, for example, because the bone marrow is very full from the inside out with blasts, and there literally isn't enough room in the bone marrow to produce healthy cells. So no healthy erythrocytes and also no healthy platelets. So it's too full with something else. And the bone marrow can also be full with products from a metabolic disease, can also be full with metastases of solid tumor. So there are many reasons why the bone marrow can be too full with something else to produce healthy cells.
Do you maybe know an example of a solid tumor patient that can actually present with, for example, pancytopenia or a bicytopenia? So a solid tumor that also spreads to the bone marrow.
Yang tahu solid kanker yang solid tapi bisa bikin gambarannya seperti leukemia. Apa? What?
The tumor of its bone itself.
Do you then think of specific, do you know a specific tumor type that you think of? A bone tumor? Which names?
Maybe I didn't have any idea.
So in the pediatric oncology, we have two big groups of the bone marrow tumors. So it's the Ewing sarcoma and it's the osteosarcoma. But actually, both metastasize first to the lungs. Ewing can also spread to the lymph nodes, but not so often. And then if you have a very extensive disease, and I know you have patients here very late, sometimes it can metastasize to the bone. But still then, not many patients with a Ewing or an osteo present with a pancytopenia, bicytopenia here. I'm going to ask Dr. Cindy. Have you seen patients with an osteosarcoma or a Ewing sarcoma that were metastasized to the bones that presented with pancytopenia because of severe invasion of the bone marrow?
For Ewing, several cases, but osteosarcoma, I haven't seen any of the cases.
So it is a possibility, but it's only when it's very extensive metastasized disease. Now, the one I was looking for is actually neuroblastoma. Neuroblastoma. So that is a case you also often have here. So those are the tumors of the adrenal gland, and they can easily metastasize to the lungs. And almost all the patients you have here is a stage 4, and they also metastasize frequently to the bone marrow and the bones. And they can present with the pancytopenia quite frequently. Yeah.
And also retinoblastoma, if you have more advanced cases, they can do that. But I think the neuroblastoma is the most frequent. Yeah. So deficiency, is that also a lessened production? If you have a severe iron deficiency, for example.
So if you think of the big groups, less production of the bone marrow or loss of the cells or destruction of the cells. So where is the problem if you think about malnutrition or nutrition deficits for folinic acid, iron, things like that?
Yang mana kalau ada defisiensi, malnutrisi, masuknya yang mana?
Is it a disease of the bone marrow itself? No. No. So if you
production.
Yeah, if you correct the deficiency, the production will normalize. Yeah.
But it belongs to the group of the less production, right? Yeah.
Yes.
And maybe one back, because I was wondering what people would answer here. Yeah, this one. Severe infection. How does that influence the bone marrow? Or is it a different way in which patients can present with an anemia, thrombocytopenia? How does that work with a severe infection? We have Dr. Riyadi here, so yeah.
Severe infection yang mana?
Maybe it can be several mechanisms, right? Yeah? How does it work?
Oh, you want to go back again? Oh.
Kalau infeksi yang mana infeksi?
Increased consumption of cell.
Yeah.
Because in severe infection, our body need more like iron to defense from the infection. So that increase the consumption of the cells. And the other.
Yeah. Usually it's because of how our body react to the infection. The immunity will produce cytokine that can disrupt the cell. That's one thing. And the other thing, of course, the decrease of production could happen also if the condition is very severe. So yeah, like Judith say, it can be a mix, but the most part that influence is increased consumption of the cell.
Yeah, and so then you have the syndrome we call DIC, right?
Yes,
Diffuse
DIC.
intravascular clotting. Yeah, yeah. And that can indeed present with the child that is tired and having signs of bleeding also.
And there are also infectious causes which lead to a decreased production of cells. Do you know examples of that?
So what infection is associated with bone marrow suppression? That your bone marrow is not functioning well anymore due to this infection.
One of the most common happen in Indonesia. No, I asked it. What is the most common happen in tropical disease?
I think I heard somebody.
Typhoid fever.
Really? Oh, I was thinking dengue. Platelets, low platelets.
Typhoid salmonella can affect the production of the bone.
Oh.
That's why they can. Yeah, that's why one of the gold standard is to do the bone marrow function to get the culture. And also that's why they will get fancy training if the typhoid is severe.
So that's salmonella TV. Yeah. Oh, great. Great. Well, not so great, but I didn't know that, so I learned something.
Quite often.
Yeah, so we all have different, epidemiologic incidences of infections, right? Because our association, if we think about it, would be Parvo B19, but that is actually not a disease that you often see, and you, on the contrary, then have Salmonella typhi or the dengue. How does it work? Thrombocytopenia, right? Yeah. Okay, then we'll get back to that.
Okay.
That's actually, is that the third mechanism how infection can influence anemia and thrombocytopenia, right? Because we had the depression of the bone marrow, like the Salmonella typhi. We had the DIC in a very severe infection, and then more bleeding and thrombosis resulting in anemia and thrombocytopenia. And the third one, like the dengue, is in the destruction of the cells. Yes.
You mentioned about the parvovirus. It happened a lot in Netherlands.
Yes. Yeah, several patients a year.
Diagnose that. Do you use a kit? PCR?
Yeah. So we
no,
have
I think we do serology primarily.
I think maybe this problem is not. It's like
diagnosed. Yeah,
like iceberg.
I think so. Might be.
We do a combination of IgM and IgG. Yeah. Yeah.
Yeah, and for a lot of these viral infections, we can also do the PCR to measure the viral load, right? Yeah.
Yeah.
That's the problem in Indonesia. We don't have the serology test to make sure that this is just a virus.
Yeah, but but in a few weeks the patient will be fine again, so it's not a problem. Okay, so just I think we are running a bit short in time, so I'll continue. Oh yeah, this is one I wanted to ask. Does every patient with low platelets have the same bleeding tendency? So a patient with platelets of 1 with ALL, or a patient with platelets of 1 with ITP, do they have the same bleeding?
Kalau tidak, kenapa? Silakan. Apakah kalau rendah trombositnya karena ITP atau rendah trombositnya karena PMC sama nggak?
We have the different tendency of the bleeding. In ITP, we can find the patient come with the complaint, sometimes have intracranial bleeding, and sometimes have like a pteche in all of body, and then in leukemia, we can find the patient came with the complaint is gingival bleeding.
Yeah.
Like
So in ITP, you see the petechiae, that they are usually not severe bleeding, and in ALL they're often severe bleeding, nosebleeds which don't stop, or gum bleeds. And can you think of a reason for that? If it's too difficult, I'll explain, but maybe somebody knows. No, okay.
But maybe the question before that is how does it work with ITP? With ITP, why do you have low thrombocytes?
Because it's autoimmune.
Autoimmune, yeah. And
So what
do
does the
you-
bone marrow do when all the platelets are destructed because of an autoimmune process?
It would increase the production of the thrombocytes.
Yeah, very good.
But in leukemia, it's mostly because of the decrease of the production of the thrombocytes. So even though the thrombocytes are low, they cannot be produced because of it's just the result of the thrombocyte is because of the decrease of the production. It's not because of something else.
Yes, that's very good. Very good. Yeah.
But so what is the normal lifespan if we talk about destruction of the thrombocytes? What is the normal lifespan of a thrombocyte? How long does it live? Coba.
28 days.
28 days. Well,
no, it's who has another idea?
It's almost correct, but it's a little bit lower.
The lifespan is 7 till 10 days.
Yes, yeah. Yeah, so it's very short. Very short. Yeah.
Yeah, so this one platelet in the ALL patient is actually the last one that was produced by the bone marrow before it stopped producing platelets at all 10 days ago. So this one platelet is very old and almost dying. In the ITP patients, this one platelet was the one that was formed an hour ago and not yet destructed by the immune system. So that's a very young one. And young platelets, they give much better coagulation than very old platelets. So for that reason, an ITP patient with low platelets will have less bleeding than, for example, an ALL patient. And you can use that if you first see the patient and you do the physical examination, and maybe you know already that the platelets are extremely low and you don't see much bleeding. It can help your differential diagnosis more in the direction of destruction of cells in the blood. Okay, we'll go on. Yeah. So the quality, yeah, the platelets are very new. They are full of coagulation factors. They will coagulate very well. So although you don't have many, their function is extremely good.
In addition to that, of course, in the leukemia patients, particularly in the AML patients, there's also this paraneoplastic phenomenon that you have a higher risk of a DIC at new diagnosis of this leukemia. And that together makes the risk of bleeding even maybe higher. Yeah.
So I was now allowing you 3 more questions to help narrowing down the differential diagnosis. But I think many of them we already mentioned, so I think I'll go on. Is the child well or ill? Somebody over there already mentioned that. Recurrent or current infection as mentioned, fever. Jaundice I didn't hear yet, but jaundice is also a good question.
Why is that a good question? Why should can you ask about jaundice to the parents if a child presents with tiredness and bleeding symptoms?
I think that's hemolytic.
Yeah, hemolytic. That could be a cause of a patient who is Kuning. And what else? Yeah, hemolytic. What else? Kind of infection?
Because in hemolytic, the more of red blood cell or destruction, and then the rest of the destruction will be different, divide to heme and globin, and the globin will change to bilirubin and biliverdin, maybe. Yeah, so
Yeah.
it could be the cause of the jaundice.
Yes. Very
So
good.
that's the hemolysis, but you asked another question
What
besides
do
the
you know?
hemolysis?
Do you know other causes of the patient being yellow? Patient Kuning.
So the hemolysis is an unconjugated hyperbilirubinemia. Yeah? If you think about conjugated hyperbilirubinemia, maybe.
Some kind of infection in which patients turn yellow for a while. Hepatitis infections.
Hepatitis is also a viral infection that is really associated with bone marrow suppression.
Oh yeah, that's a good. Yeah. 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 So malaria should be in the differential diagnosis. Other complaints we talked about a bit already, and the family history. So what would you ask about the family, or would you just do an open question? How about specific diseases in your family? Hemophilia? Yeah? Yeah, good question. And would you ask that if it was a boy or a girl, or doesn't it matter? A boy, yes, yes. Very good. Okay. We'll go on. Okay, now this is I think also very important. Now the patient has arrived in Bandung in your hospital. It's in the emergency room, and you are going to do the physical examination. And you made this raw differential diagnosis in your head. And what would you be looking for, and how would it direct your differential diagnosis? I think almost everything is correct, but why?
We can find the conjunctivitis anemic, and we can find organomegaly.
Yeah.
What kind of organs? Really good. Yeah.
Hepatosplenomegaly.
Yeah.
Yes.
And how would that help if you have that? In your differential diagnosis, so you have this patient, anemia, maybe probably thrombocytopenia, we think, because of the bleeding symptoms on the skin. Then having a hepatosplenomegaly.
If we found organomegaly, we can think it's about leukemia.
Yes.
Leukemia, yeah, very
really
good.
Yeah.
And for example, in the metabolic disease, do you sometimes have swollen organs? Do you know? Maybe you don't see many metabolic patients here. they often have at least hepatomegaly because depending on which metabolic disease, but some byproducts can accumulate in the bone marrow or in the liver or in both. So now you have been looking for signs of anemia and hepatosplenomegaly. And signs of anemia, you looked in the conjunctivi, but what other findings would support your differential diagnosis of at least anemia? So paleness of the conjunctivi, anything else maybe? A murmur.
Yes.
Yeah,
Murmur
very
in
good.
anemia.
Yeah, very good. And something about the heart rate maybe?
I think increased heart rate.
Increased. Yeah, tachycardia. Very good. So if you think, well, this could be a new leukemia patient, what other signs would you look for in the physical examination? Lymph nodes, yes, very good. And what do you know about the lymph nodes in between our lungs, in the mediastinum? Can they be involved in, for example, ALL? Who does think that they can be involved?
Maybe raise your hands.
No? Who does think they can never be involved? Raise your hand if you think that. Your patient just died because you didn't make a decision. No, it's okay. Okay. Yeah. So, okay, the answer is they can be involved. But what can happen if you have an enlarged mediastinum?
Shortness of breath.
Yeah, shortness of breathing. Yes, and could the position of the body be of influence of the shortness of breathing? Yeah. Yeah. What would be worse for the patient? Lying down is worse? Yeah. Yeah. So you can ask for that, and you can also look for it in your physical examination. And what if there's compression not only of the airway, but also of some vessels? Do you know what the name is of such a syndrome?
Vena cava superior syndrome.
Yeah, very good. Vena cava superior syndrome.
So if you have a child with a vena cava superior syndrome, and if you can see it, what then do you see on the patient? Because sometimes you cannot see it and they have complaints, but otherwise you can see it.
Maybe we can find some udem interface and hyperemesis and increase in the JVP.
Yeah.
And we can already see a sign of like autopneu in the patients and cough. But
Cough, yes, yes. I think it's all excellent answers. Could everyone hear it? So it's orthopneu, shortness of breath lying down. You can see edema of the head and high pressure in the veins of the neck, central venous pressure. Cough.
Yeah, and maybe patients can also complain of like headache, dizziness, visual disturbances, but you have to ask for that. Yeah.
Yeah.
But actually, you can also have zero symptoms, and if you don't have any complaint and you don't see anything at the physical examination, does that mean that your child does not have an enlarged mediastinum? If everything is well in the anamnesis and in the physical examination, Does that make you sure that there's no enlarged mediastinum?
Thorax photo.
Yeah, thorax photo. Yeah.
Yeah, because you can have no symptoms at all, and still, if you make the X-ray, you are impressed. And it's good to do it in both directions because that helps in really good interpretation.
So to save some time, I went to the next slide. So I think the first thing that you should notice if you do a physical examination is the patient ill or well? And that already helps you differentiate as well in the list that you just made. Temperature and vitals. I would always make a growth chart and see what the target height is of the patient. Do you know why that could be important? Some of the diseases. Yeah, chronic disease. Yeah, that's very good. Sometimes in chronic disease, you can see that the child was growing normal at first and then started slowing down with the growth rate. Ya.
Pertanyaannya apa sih?
Penurunan nafsu makan. Penurunan nafsu makan. Terus maybe loss of appetite.
Appetite, yes.
Yes, and also increase of BMR in patient with cancer.
Yeah.
Metabolic apa sih?
BMI, I think decrease, you mean. Yes, yes. And also, for example, if you think about deficiencies as a cause of the problem. But also, and also with some specific bone marrow failure syndrome, so we'll come to that later. I would always look at dysmorphic features. So, for example, if you see a patient with evident Down syndrome, does that help you make the differential diagnosis? Yes.
How? If this patient that we talk about has a Down syndrome, what do you then think is the most likely diagnosis?
Yeah, leukemia.
Yes. Yeah.
Yeah.
Because your risk of the leukemia is like 20% higher?
Yeah.
20 times higher, sorry, as in the normal
20 times, yes.
population.
And but also, for example, celiac disease could also produce this clinical picture. So, but it would help make your differential diagnosis. If you saw some specific dysmorphic features, can really help. Skin color we talked about, and the skin by itself, like café au lait spots, hypopigmentation, petechiae. Would that help you if you found café au lait spots?
Maybe we can think on a neurofibroma.
Yeah, neurofibromatosis.
Really
Yes.
good. Yeah.
Yeah, and children with neurofibromatosis, they are prone to other diseases as well, like JMML, juvenile myelomonocytic leukemia.
But also like brain tumors, low-grade gliomas. Yeah. It's also one of the neurofibromatosis diseases.
So I would also want you to look at the gingiva. Why do you think that is?
You get an extra chocolate if you have this one correct.
We can find a hyperplasia gingiva.
Yeah, that's what I was looking for.
And AML?
AML, yes. Yeah, I think you just earned yourself some chocolate. Okay. And if it's a boy, I would also like you to have a look at the testes. And what can we find in the testes?
Leukemia.
Leukemia, yeah, correct. Very good.
Why do we think it's important that you know at the diagnosis of a leukemia whether or not the testes is enlarged? Why is that important? We know that the leukemia can present in the testes, in the CNS as well. It originates in the bone marrow, but it can spread to the CNS, can start in the testes. Why is it important to know? Before you start the treatments.
For the treatment, the chemotherapy regimen, and then for the prognosis.
Yeah, because you want to be sure that you actually treat well, so you want to see the response to treatment. So for that, you always need to know where, at the start of the treatment, where is my disease? And then you have to evaluate. So the child with a mediastinal mass, you need to reevaluate after the end of induction, is my mediastinal mass gone? You need to reevaluate, has my testis been normalized again? And sometimes additional treatment is needed, or more intense treatment, or maybe radiotherapy is needed. So it's very important, yeah. Okay, we have some results.
Yeah, and the HB, I'm sorry, I put it in Dutch values, but it's very low. It's very low.
This is like 4.3 or something in your units.
So low platelets, low leukocytes, so it's pancytopenia or aplasia. And you may order 5 tests from the lab.
Only 5?
And then the money uang is bankroet.
It's the same word, right? In Bahasa Indonesia?
Bankroet, yeah, that is.
Yeah, 5 essential tests.
For the further test, we can check the diff count and peripheral morphology, and we check for the complication from the maybe this leukemia, for the tumor lysis syndrome, like urea creatinine, uric acid, and electrolyte of the patients.
Yeah.
Thanks so
very
much.
good suggestions.
Yeah. Any other suggestions? Because we don't only have leukemia in the differential,
LDH?
Yes. What is the difference between the LDH and the uric acid? What does it point to? And can it help in discriminating what is happening in the child?
So maybe start with the LDH. What can be the reason for the LDH to be high?
You will get chocolate, whether it's wrong or right. It doesn't matter.
Because of cell turnover.
Yeah, very good. Okay. And for the bonus question, uric acid, if that's high, what can be the reason for that? So uric acid's also cell turnover, but there is a difference. Can anybody think of the difference?
If uric acid is more destruction, the more the more the cell is being destruct, the level of uric acid is more higher.
Almost.
Yeah, that is true for a specific type of cell. So what part of the cell does the uric acid originate from?
So it's like a garbage product, the uric acid. But it's the garbage product of the nucleotides, of the DNA.
Yeah.
So
Yeah.
only cells that have a nucleus can produce
Uric acid,
high levels of the
urinezuur.
uric acid.
Uric acid. So all cells will produce LDH when they are destructed, but only cells with a nucleus will also produce uric acid.
So if we talk about the bone marrow, we have the hemoglobin, right? Hemoglobin cells, thrombocytes, and we have the leukocytes. Which of those three cells actually has a nucleus? Oh,
Only the leukocytes, yes.
Yeah.
So if you only have hemolysis, your LDH will be high and your uric acid will be normal. Yeah. And if you have leukemia, your LDH will be high and uric acid high as well. Yes. So that's the difference.
And
So
maybe-
remember that. That's really handy.
And maybe it's good to mention that in leukemia, you sometimes can have spontaneous tumor lysis, that you already measure when the patient enters your hospital. You already measure a high LDH or a high uric acid. That can be the case. But more often, we only see it happening after you start the treatment. And then you see, because of the treatment, you will destruct the malignant cells. And then you will see high LDH, high uric acid. So it's very important not to measure it only before, but during treatment. We would do it like daily. I know that's not the case here, but if you think of patients at higher risk, for example, if they have a hyperleukocytosis, so many more cells can be responding to the therapy, you should closely monitor tumor lysis. Yeah.
So this is what we came up with. Differential of the leukocytes. You already mentioned. That's a very good suggestion. LDH and uric acid, you know the difference now and how you can use it. I was also thinking about reticulocytes or MCV, because that can tell you something about the underlying process. Do you know how they relate to each other? Do you know what reticulocytes are? Reticulocytes? Yes. Yeah. What is it?
A reticulocyte is a young red cell.
Yes. Very good. Young red cell.
How does it influence your diagnosis if you find in your lab that your reticulocytes are very lower than normal? In a child with anemia?
With anemia, is a reticulocyte is higher.
If it is low.
cells from my reticulocyte will go up and it will help. But in your patient with the anemia or type 4, you have low reticulocytes. What does it make you think if you're referring to leukocytes?
Because the production of leukocytes is higher, so decrease the red blood cell. The leukocyte is higher.
So you mean in a way that you have the problem is in the production of the bone marrow, that the bone marrow is not capable of making new red blood cells. Yeah. So if you think again of the three groups, you had the problem of decreased production or increased loss or increased destruction, then you know that the problem is actually in decreased production in the bone marrow. Yeah, that there is a problem with the bone marrow. Yeah.
Yeah, and if, for example, the reticulocytes are really high, then you would think of an immunological problem in which the red blood cells are destroyed and the bone marrow is producing at high speed new red blood cells. And a young red blood cell, is it larger or smaller than an old one?
Larger. Larger.
Larger, yes.
How long does a red blood cell live? 3 months. 3
Very
months.
good. So if you are working in a hospital where it's not possible to measure the reticulocytes, but you still can measure MCV, could that help you differentiate as well? Because it's an easy test, it's cheap. So if the reticulocyte count is high in the patient, what would you expect the MCV to be? High.
High.
Yeah, also high. So it can, it is a similar test. Well, not really similar test, but the result can help you in the same way. Okay, I'll go to the next one. So if you saw this, what would be the most likely diagnosis?
So these are like spot diagnoses that we are showing you now. What's the name for this? Yeah.
I recognize there is bleeding from fracture. There is bleeding intracranially, or
It can also be traumatic, that's true. But if this is a child which didn't have a trauma, what is raccoon's eye suggestive of?
Neuroblastoma.
Yeah, very good. Neuroblastoma. I think some more chocolates? No, oh, okay.
And these children can be misdiagnosed as child battering. Yeah? Yeah. Yeah, child abuse. Yeah. How many time do we still have left?
Yeah, we are already
Past
10
the time.
minuten laat.
Okay.
We zijn nog wel een kwartier later.
Yeah.
So maybe we do this and
then
we stop at the same point as in
yeah, I think so, yeah.
Okay, so this we will go a little bit quicker. If you see this, yeah, you know.
Systemic lupus erythematosus.
Yeah, SLA. Yes, very good. And this, yeah, gingiva hyperplasia with AML. Yeah, we already knew that.
You can also sometimes see it in children who are actually being treated with amlodipine. And there's another one, cyclosporin as well.
Cyclosporin, yes.
Then you can also get gingiva hyperplasia.
And this maybe it's a bit hard to see, but here's a café au lait spot, and this is deep pigmentation. And then you see these hands in one patient.
It's already mentioned earlier that we talked about neurofibromatose. Yeah.
No. I was looking at a syndrome in which you don't have
combination.
cafe au lait spots, but also
Abnormal thumbs and cafe au lait spots combined. What kind of syndrome can you think about?
do you know, it is very suggestive of Fanconi anemia. Have you heard about that? Yes?
McCartney-Albright syndrome.
Excuse me?
It's Albright syndrome.
McCune-Albright.
McCune-Albright, but they don't have those thumbs. So the thumbs is really suggestive of Fanconi anemia. And would the family history be helpful if it was a patient with Fanconi anemia? I'll show you. Oh, sorry, it was one slide in between. In Fanconi anemia, 70% of patients have stigmata, and they have a mouse-like face. They have these spots, these cafe au lait spots, and I didn't even mention it. The cafe au lait spots and the depigmentations, like I showed you, are very common. How much? I don't know, but very, very often. And they have a growth below the curve, but you might not notice it if you don't put the length of the parents in the curve. Abnormal fingers and toes, and most common the thumbs or the first radius extra, or sometimes they miss a part of, they have very short thumb or something like that. Abnormalities of the kidneys, like horseshoe kidney, microphthalmia, but you can not always see it from the outside. You have to ask the ophthalmologist. And impaired hearing. And the family history, I was going to tell you because that's difficult. It is autosomal recessive. So usually the family history will be completely normal, unless there's another child in the family which already has bone marrow failure.
So we talked about problems in the bone marrow, and that this is one of the very rare causes, right? An inherited genetic cause of bone marrow failure. Then I was told that maybe up till the age of 18, almost like 80 or 90% of the patients with the Fanconi anemia develop somewhere in their lifespan pancytopenia.
Yeah. And it cannot be corrected anymore. So does anybody know what the problem is in Fanconi anemia?
Maybe we should explain for the sake of the time.
So it is a repair problem, DNA repair, and the test is a mitomycin test in which we incubate cells of the patient with mitomycin, which is like a chemotherapeutic agent, and it will make a lot of mistakes in the chromosomes. And then you can test the repair mechanism to see how many chromosomes are normally repaired and how many abnormally. And we do it always simultaneously with a healthy donor. And here you see like this triangle. It should not be a triangle. This is even tetra, like two chromosomes fused in the middle. And here's a break in the chromatide. This one does have two centers. So there's a lot of mistakes which were not repaired in the normal way. And that's very suggestive of Fanconi anemia. And because we are already running very late, we'll stop here.
Yeah, but maybe the take-home message is think in big groups if you have a patient. So think in the group, can it be like, in this case, we were talking about problems with hemoglobin, thrombocytes, maybe leukocytes. So can it be like destruction? Can it be loss, or can it be decreased production? That will help you further in thinking about differential diagnosis, and then use your physical examination and little lab results to make specific diagnosis much more or much less likely. Okay, thank you so much.
I think you give 2 chocolates to our speaker. Okay, I think we can wrap up for today. Thank you for your participation, all, and also for our speaker. Thank you for sharing your expertise for this. I will close this session with take a picture together. Okay, come on, take a picture together. I know your face is already bad right now. Oh yeah, okay. Okay, and then while preparing for taking picture, is there any feedback? What do you think about this today's session? Come on, come on. Anyone who wants to give? Yeah. You can give your feedback. Is it this clinic? I think come here, Gita. Gita want to say something. Come on. Are you? Our friends from pediatric surgery, come on. Come on. Yeah. Come on. Come on. Yeah. Gita, silakan. What do you think about today's session, especially clinical reasoning session?
Yeah, thank you for the sharing, and yeah, thank you for the sharing and for the chocolate. And then
it tells us how to diagnose patient structure, more structural, and yeah, and more knowledge about leukemia and how to differential diagnose when we visit a patient or we meet a patient with leukemia, and what kind of disease we can think besides leukemia and not only leukemia. I think that's all. Yeah.
Thanks. And what should we not do next time? So we are used in the Netherlands. We always say, this went well. This maybe you could have done differently. And in total, it's like this. And then you end. It's like the sandwich. Some positive and then some feedback how you can improve. And then in the end, ends with something positive. So. Because we're doing it for you guys, so we really want to adjust. Well, you can also later give the feedback to Dr. Sari, because for us it's important, right? We do it for you, so if it should be a little bit different, it's fine. Let us know. Otherwise, some other time, right? Yeah, don't be shy. You can say.
I wanna give something feedback. Maybe something different in the next. Maybe we can share about how to manage a patient in Netherlands and Indonesia. What kind of a difference when we manage an holistic? How to improve their psychological and something else, and yeah, not only about cure someone, but also in the holistic way. I think that's all.
Yeah, that's very nice.
Thank you.
About the count, yeah. So what is the difference? So we're trying to have like Indonesia just do, but now we have to think why we do that, why we do that, why we should check, examine, blah blah blah, why we diagnose, why. So this one thinks that maybe we lack of it. We just like follow the guideline without, the reason behind it. But actually, we have to learn why, because we have to explain to our patient. We have to convince the insurance, for example. So we have to know whatever you gave to the patient. Yeah.
And it helps you not doing too many tests on one patient, because if you already thought what are you looking for, then maybe 5 tests is enough and you don't have to do 25.
Yeah. Yeah, and maybe what you said about the holistic approach, what we did in Jogja this last week, is that we had a discussion of a difficult patient, and that you present the case, and then we respond to that, and we share our different experiences. This was a case of a terminal patient, of one with a lot of pain. Should you do wound care? How is the pain medication? Things like that. Yeah.
Yeah, and we included the nurses, so that was really, I thought, really nice, because we had the nursing staff, but also the residents and doctors, fellows, and everybody could give his or her opinion, because with the whole team you have to take care of such a patient and a family, and it helps if you have the same ideas about it, and if not, to talk to each other, because it can also for yourself emotionally be difficult, and that might influence the way you care for a patient and a family.
Yeah. So maybe an idea for next time, right? Yeah. Thank you.
Siapa yang mau duduk? Ya, let's go. Silakan duduk. Come on. Mana tuh kayak motonya nggak ada? Ya, silakan duduk depan. Duduk, duduk. Ya, duduk, duduk. Ya. Yang dapat Silver Queen tolong diliatin nanti.